Welcome to the latest installment of the AJT Journal Club series. Today's Journal Club on a retrospective analysis of VCA in the United States after 5 years of the final rule is hosted by the AST Vascularized Composite Allotransplantation Advisory Council. Our speaker today will be Dr. Holly Lewis from Duke University Medical Center and Dr. Hatem Amer from Mayo Clinic in Rochester. Before we begin our main presentation, we have a few housekeeping notes to help you engage with today's discussion. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This journal club is being recorded and the archive will be available on the MyAST website and the AST YouTube channel within 24 to 48 hours after the session. Please note that your lines have all been muted so that only the presenters can be heard for the archived recording. If you have a question for our panelists during the journal club, we encourage you to participate by using the questions section in the Zoom webinar panel to submit your questions for consideration. Content questions submitted via the chat section may be missed during the presentation. If there are questions we do not have time for, we will either answer them individually offline, or we will post the full question with the answer on the website following the journal club. Finally, when you log off at the conclusion of today's journal club, you will see a link to a short survey to complete. Please fill out the survey to help us keep our content current and engaging. I will now turn the session over to our moderator, Dr. Hatem Amer, to begin our presentation.
Thank you everyone for joining us for this journal club today from the AJT article. Essentially, to give you some background, I'm a transplant nephrologist and the medical director for the reconstructive transplant program in Rochester, Minnesota. And today we are discussing an important article. And the reason it's important is that at this point, really VCA has established itself as a technique that we can employ. The question is who would benefit, what are the actual outcomes that we can guide patients in their decision-making, and how to lead the field forward to benefit our patients. And it gives me a distinct honor to present today's speaker, Dr. Holly Lewis, who conducted this study. She's the lead author. Dr. Linda Sendalis is the senior author. And essentially, Dr. Lewis is a rising star in general surgery. She's a PGY2, and her clinical research interest includes tissue engineering and reconstructive surgery, so very pertinent to this field. She had earned her MD and PhD degrees at Amer University and is focusing on immunology and chemical biology. She's developing a hydrogel models for wound healing and cell therapy with the Duke School of Engineering. And she conducted the study that we are going to be hearing about today. So that without any further delay, we'll have Dr. Lewis begin. One note is please take a moment and write on the chat what your background is. Are you a surgeon? Which part of the country are you from? Or if you're overseas, would like to know the individuals who are interested in this topic and participating with us today. Without any further delay, Dr. Lewis, please proceed.
Thank you very much, Dr. Amer, and thank you as well to the AST VCA Advisory Council for this opportunity to discuss our research. To begin with, I have no conflicts of interest to disclose. And this is the article that we'll be discussing today. Published within the past year in AJT, we conducted a retrospective analysis of OPTN data after 5 years of the final rule. Now, the final rule was instituted in 2014. It's been a nationwide initiative to begin the mandatory collection and aggregation of all transplantation outcomes and biometric clinical data for vascularized composite LFs. In conjunction with solid organ transplantation, the OPTN helped to collect this data for all transplanted organs nationwide. So this was our effort to analyze the outcomes and the immunotherapy data after the first 5 years of this rule being in place. As many of us know here in this audience, a vascularized composite allograft is a tissue transplantation that has a minimum set characteristics. The VCA must be vascularized and contains a composite of different types of tissues, be it skin or bone, or blood vessel. The organ is transplanted as one functional unit from a human recipient into a human recipient. It's minimally manipulated. It does not include any biomedical or engineering device. Because it is a vascularized allograft, it is subject to ischemia as well as allograft rejection. So typically all VCAs do require some degree of immune suppressive medications with the concomitant risks that go along with immune suppression, be they infectious or otherwise. So to begin with, we requested data from the OPTN, looking at all VCAs reported to this body. Within the database, it includes 62 total VCA recipients, dating all the way back to 1999, when VCA was first getting started in the United States. This entire database was downloaded by us in March 2019. It comes as a standardized data set analysis called the STAR format. And for our study, we particularly focused on this 5-year window during which the final rule has been implemented. That brings it to a total of 36 patients, which will be the subject of our analysis. These 36 patients are defined by a host of different variables. It's roughly divided into preoperative variables and postoperative variables. And we'll be discussing this data throughout our talk today. The analysis comes to us from the OPTN as a SAS database file, which I used SAS as well as SAS coding and Prism to analyze the data. And a lot of the figures are rendered using the Adobe InDesign and PowerPoint format. So speaking broadly, this is our overall perspective of how many VCAs have occurred in the United States in the last 5 years and reported to the OPTN. The most frequently reported VCA was the uterus. There were 16 of these total nationwide reported. The majority of them occurred with a living donor. The next most commonly reported VCA was the upper extremity, with most of those recipients receiving a bilateral upper extremity transplantation. Face comes in next as the most frequently reported, abdominal wall, penile, and scalp transplantation. Now, looking grossly at all of these organs, there is a relatively high degree of the high percentage of the grafts remaining in place throughout these 5-year periods of analysis that we looked through. When we look at a histogram of which types of organs are being transplanted nationwide, again, we can see here that the most commonly reported VCA is the uterus, being transplanted 10 or 11 total. And then you can see the other frequencies for different VCA organs nationwide. When we look at these on a temporal perspective, beginning in 2014 is when the first VCA reporting mandates started. And you can see the trends over the last few years in terms of the increasing frequency with which uterus transplantation has been occurring, as well as the upper extremity transplants are still occurring with some frequency. We'll begin our discussions with the uterus VCA as it's the most frequently reported. This is a Kaplan-Meier figure demonstrating the overall graft survival as reported to the VCA, broken down between the donor classification, whether it was a deceased donor organ or a living donor that was transplanted into the recipient. Of note, I will draw your attention to the x-axis here, in which at least one of these organs is documented to have been in place for well in excess of 9 months, which would be consistent with the amount of time to gestate and deliver a human child. Looking grossly, we'll discuss the immunotherapy tactics used for the living donor uterus transplantation. These patients do not have any upfront immunophenotyping characterized. The HLA mismatch data is not reported for these recipients. The induction immune suppression for the recipients undergoing transplantation typically consists of thymoglobulin and steroids, which is consistent with what we see in other transplant protocols. These patients also receive maintenance immune suppression, consisting of oral tacrolimus, oral mycophenolate mofetil, steroids, azathioprine, and everolimus. You'll see throughout our talk that we'll use this format to describe the immune therapies. These patients are also documented to undergo acute rejection episodes, and these are treated in the acute setting. For the uterus, they were treated with tacrolimus, IVIG, or short courses of oral steroids. When we look at the deceased donor uterus transplant recipients, these patients do report the average amount of HLA mismatch occurring at between 5 and 6 loci of difference between those donor and recipient pairings. Again, patients are induced pharmacologically with thymoglobulin and steroids. And these recipients, again, are maintained in the long term with tacrolimus, mycophenolate, steroids, and azathioprine. Of note, for the deceased donor uterus recipients, none of these patients were reported to undergo an acute rejection episode. We'll shift now to discuss upper extremity transplantation. And here we have grouped together all hand transplant recipients, bilateral and unilateral recipients. There were a total of 10 patients to receive this transplant. Apart from some early losses documented in the OPTN database, you'll see that overall there's a very high rate of the hand transplant recipients maintaining their graft for well in excess of 2 to 3 years. This is notable that the database is 5 years in its total time, so there's overall excellent outcomes here. When we turn to the immunotherapies, we will break this down by unilateral and bilateral. Again, we see that the HLA mismatch is reported at a difference of 4 loci between the recipients and the donors. Induction immunotherapy is again consistent with other organs consisting of steroids, thymo, and maintenance drugs are again tacrolimus, mycophenolate, steroids. Rejection episodes are reported among the unilateral hand transplant recipients. And when those do occur, they were reportedly treated with oral steroids, but also topical agents, such as topical tacrolimus and topical steroids. Excuse me. When we turn to the bilateral hand recipients, the immunotherapy protocols are similar. Again, differing in an average of 5 loci for HLA mismatching. These patients also undergo standard steroids, thymoglobulin induction. Some of these patients also receiving other drugs, including alemtuzumab and basiliximab. Maintenance therapies are, again, consistent with the prior VCA reports. The number of acute rejection episodes is a distinct variable reported in the OPTN outcomes database. In this database, there was one recipient who was documented as undergoing 7 distinct rejection episodes. At the time of the analysis, after this 5-year period, this person was not documented to have fully lost their graft, but they had just had 7 separate acute rejection episodes. And again, these rejections are treated with similar agents as before mentioned, steroids, topical agents, as with other hand transplant rejections, and occasional usage of plasmapheresis and IVIG. The upper extremity VCA function scores deserves special discussion here. Within the database, there are 3 separate types of metrics that are used to describe the patient outcome, functional perspective. The first is the Carroll test, developed in 1964 at Baltimore City Hospital by Dr. Carroll. This is a standardized assessment of a patient using their hand to perform various tasks around their home. It consists of prehensile tasks, picking things up and moving them from one place to another. The DASH score is the disability of arm and shoulder, and it is commonly used, the arm, shoulder, and hand, and it's commonly used in upper extremity surgery research. It describes disability, whereas the Carroll test describes function in a positive metric. The Semmes-Weinstein is a test of sensory ability. It's of note for upper extremity recipients because it helps to describe the patient's ability to regain protective sensation. When we look at the upper extremity VCA functional scores, there's notable increase for these recipients documented. However, one patient in the unilateral hand transplant group has data reported preoperatively and postoperatively such that we can describe their improvements. The other scores are not reported, so it's difficult to assess the improvement from baseline to postoperative. Turning to the bilateral hand recipients, there's an average improvement of 28 points on the Carroll test score, and an average improvement of 18 points on the DASH score. And the Sims-Weinstein, the mean improvement score here is 3 millimeters, which is consistent with some degree of return of the protective sensation ability for the upper extremity. We turn now to FACE immunotherapy protocols. There were 6 recipients documented in the OPTN database. These patients differ, the recipients and the donors, on an average HLA mismatch of 5 loci. The induction immunotherapies were again consistent with the prior transplants, as were the maintenance immunotherapies. These patients, again, with the face and the hand, are receiving topical agents on occasion. When we look at the rejection episodes and the treatments for those rejection episodes, we again notice that steroids and thymoglobulin are commonly used agents. The FACE VCA group also describes functional outcomes. For these patients, I will note for the 6 patients reported in the database, none of those patients are documented to have fully lost their graft at the end of the point of analysis. And the mean number of days for the FACE transplant recipient to have their graft was close to a year. When we look at the functional outcomes of FACE transplantation, the variables here relate to the function regained by having a new face applied to a wounded area. A number of these patients are documented to no longer require tracheostomies. They can regain the ability to smell things or to take food by mouth and have their feeding tubes removed. These are the functional outcomes that are reported among a high number of these FACE transplant recipients. We shift now to the abdominal wall VCA immunotherapy. These patients, overall, there were 2 such transplants reported, differing from each other, from donor and recipient, by an average HLA mismatch of 5 loci. These patients also are reportedly to not have lost their graft for over a year average time in situ. Typical induction immune therapies, here again, consisting of thymoglobulin and steroids, and maintenance medications. The abdominal wall transplants are here reported to be receiving everolimus, sirolimus, tacrolimus, and cyclosporine. This is the only group that's documented as receiving cyclosporine as a maintenance immune therapy. And at the time of analysis, there were no reported rejection episodes for either of these abdominal wall VCAs. There is one recipient in the OPTN database who is reported to undergo a penile transplantation. This person differed from their donor in an average HLA mismatch of 2 loci. And that graft is reportedly in place for close to a year at the time of my analysis. Steroids and thymoglobulin were being used to induce that patient. Tacrolimus and steroids were being used as a maintenance immune therapy. This patient was reported to undergo an acute rejection episode, and it was treated with thymoglobulin, topical tacrolimus, and oral dose of steroids. There's also one transplanted scalp reported in the OPTN database. This person differed from their donor at an average HLA mismatch of 6 loci. This graft is documented as being in situ for well over 2 or 3 years here. A total, at the time of my analysis, it had been in place for 1,300 days. Induction immune therapy was documented as thymoglobulin. This person is reportedly maintained on tacrolimus, mycophenolate, and steroids by mouth. And according to this OPTN database, this person has never experienced an acute rejection episode. So we will summarize our data analysis in a few major points. This is, of course, a huge milestone forward for the whole field of VCA. To include this database collection within the OPTN as one nationalized collecting center is very important for all of us doing this research. It helps us to coordinate with one another across the country to help record and report data outcomes. Of note, although the submission of this data is mandatory to the OPTN, there are, as I described, hundreds of variables in this database. And although submission of some of these variables is mandatory, the completion of each one of those entries is not mandatory. So when we look at the data, there's actually a high degree of missingness for variables. 2 data points I'll draw attention to is that about half of the patients in the database do not report data for the calculated panel reactive antibody score. This is a metric widely used in transplantation research, and it's often reported for solid organ transplant patients, but it's not highly reported in the VCA outcomes data. Similarly, close to half of these patients do not report data into the OPTN regarding their baseline creatinine. If you're interested in these data, I will recommend you look at our supplemental figures online, where we describe the missingness of a high number of variables for the database. Some of the best recorded data in this outcomes study is immunotherapies, perioperative variables, such as whether the patient was given anticoagulation or antibiotics in the peri-op setting. These are consistent with well-documented clinical variables. Was a patient given a drug or not? Yes, no. Those things are reported with high fidelity in a clinical environment. And the experience of graft rejection is reported at a high degree of fidelity, as is a graft loss. Those are very important, significant events clinically, so those are reported at a high degree of fidelity. When we look overall at the functional data, I think it's important for us to look at the functional outcomes that patients are reportedly receiving improved function from their transplanted organ. Of note, the uterus is the most frequently reported VC in this database, with at least one of those patients documented to have a transplant in situ for well over 9 months. However, the OPTN database does not have any variables to describe functional outcomes. The putative indication for a uterus transplantation is to carry and deliver a healthy human child. There are no variables in the OPTN to document the number of intrauterine inseminations or in vitro fertilizations, the number of implantations, or the number of live births. When we look at the face transplant patients, these patients, when we look at those different functionality outcomes, removing the peg, removing the trach, those patients have functional data reported for well over 80% of the options available to them. Whereas when we look at the hand transplant recipients, overall 43% of those functional data points have data reported to the OPTN. And it's my belief that this represents an important growth opportunity for all of us in the VCA to work harder together on ensuring that we're able to report the immense functional improvement that our patients can receive from these transplants. One other aspect that I think is an important growth opportunity is in the world of immunophenotyping. We know from solid organ transplantation that HLA matching varies. The importance of HLA matching varies depending on what type of organ is transplanted. A number of recent studies have been performed in kidney recipients, liver recipients, and heart recipients, looking at whether or not the role of HLA mismatch has a bearing on clinical outcomes for the transplantation. When we look at the OPTN database for VCAs, less than half of patients have reported the degree of donor-recipient HLA mismatch. And I think that this is an important opportunity for all of us in the field to work on improving the reporting of our HLA mismatch variables. We could have the opportunity to address a number of important foundational questions in transplantation immunology when we look at this parameter. In particular, looking at living donor VCAs, such as the uterus. The uterus is the only VCA that's reported to undergo transplant from a living donor to a living recipient. And whether those patients are related or unrelated, those could be very important questions for us to analyze as a team. And it would be important for all of us to communicate to the best of our ability to make sure that we can advance this field together. So with that, I will pause my talk there and thank each and every one of you for attending, and with special and important thanks for every organ donor nationwide who contributes, who gives the gift of life. Whether it's solid organs or VCA organs, this entire field and each of us owes so much gratitude to the recipients and the patients in the transplantation community, in addition to all of the caregivers, the family members, and the healthcare workers, the researchers who help to make this amazing opportunity to give and restore life and function. I would also like to thank, in particular, my mentors here at Duke, Dr. Kirk, Dr. Sandales, and Dr. McGalley, as well as important colleagues that I have had in development of this biostatistical analysis, including Dr. Melanson, Dr. Pesco, and Alex McConnell. With that, I will invite all of you that if you have any questions about this data or you would like to discuss it more, we welcome your questions now, of course. But at the bottom of this slide is my email address as well as my Twitter handle. I would love to engage with each one of you in regard to the outcomes, immunotherapy, and the steps forward for VCA. So please feel free to reach out to me via email. I'll be happy to discuss with you, within the confines of OPTN confidentiality, of course. But I would encourage you to please engage with one another and with us as we work to advance this field. Thank you.
Thank you so much, Dr. Lewis. Very interesting presentation. Questions are coming up, and I've got some as well. So one question is, the OPTN was given the charge of following VCA and essentially subjecting them to the same standards as solid organs in 2014. But they went above and beyond, and they offered to retrospectively include transplant data from the transplants that were done before they took charge. And as from your manuscript shows, they did have an additional set of patients. They have a total of 62, and only 36 were those that were after the change in the final rule. So one question is, when you came to do this analysis, why did you restrict it to only after the implementation of the final rule to VCA?
Well, thank you for that question. When we received the whole raw data, Dr. Sandales and I discussed what would be the optimal way to describe this data set and to kind of demonstrate the outcomes overall. It is notable when you look through the raw data that, dating back to 1999 and 2000, you can see important biometrics and outcomes data being documented. Mm-hmm. The reason that we chose to focus on that 5-year period since the final rule is that we wanted to demonstrate the tremendous value added of OPTN oversight. It's important and notable that there is data reported in the pre-final rule time point, but that data is less frequently reported. Some of that data is less rich from a data science perspective. So by focusing on the 5-year period of increased importance and increased scrutiny on reporting, it allowed us to demonstrate to the reader, look at, because of the OPTN, look at how much better we have become. This is a value-added institution that we want to kind of demonstrate and show the steps forward.
Okay. Do we know, compared to the pre-2014 versus the post-2014 data, since it was voluntary, the proportion of programs that have reported or the number of transplants per program that were reported?
That question would require kind of like looking through the database, before and after the final rule on a granular level on per program and reporting. And when we were describing how to present this data, we chose to not analyze the data on a per program or per region statistical method, because when we look at the number of VCA centers nationwide, granted there are not that many of them across the country, and in order to preserve the confidentiality of each individual center, we elected to not perform those per program variables. A researcher who wanted to look at them to that variable would be able to request analysis data from the OPTN themselves, but that was not a field of inquiry that we particularly investigated.
And I've grouped this. There's several questions here that's sort of on the same line. So for the uterus transplants, the HLA matching between the donor and the recipient for the longest surviving uterus at 436 days, do we know what the matching was? And on the same line, someone wrote, most uterine and hand transplants are rejected within a week, indicating that these VCAs are highly immunogenic than other solid organs. Is there any plan at UNOS level to capture HLA compatibility? Pre-transplant antibody profiles and post-transplant donor-specific antibodies.
Well, that's several questions. I'll try to break them all down one by one. I don't have the raw data in front of me, but I do believe that it was about 5 to 6 loci. That's the average reported mismatch degree. We had initially looked at the raw data and tried to perform t-tests of statistical significance to see if there was a statistically significant difference between HLA matching and graft loss. However, we were not able to do those statistics simply because the N was too small. In relation to the question about the immunogenicity and the rejection of hand and uterus transplantations, I will agree with the speaker there, or the question asker there. Dating back to the time of Peter Medawar, it's been very well documented that soft tissue transplantation and skin inclusion in transplantation is a very immunogenic organ. It's been decades and decades for all of us in this field, close to a century, in fact, working on identifying the optimal immune suppression therapies for these organs. I can't say whether most transplants are rejected within a week. I'm not sure that that's what my analysis of the OPTN data would show. But I certainly acknowledge that there's a challenge from an immunological perspective. But I think when we look at the improvements that have come since 1998, improvements in microvascular surgery technique, improvements in immunotherapy medications, including shifting away from drugs like cyclosporin and using tacrolimus, mycophenolate. And here at Duke, we're also using belatacept in our VCA transplant recipients. There are certain advantages that are continuing to happen in the field of VCA that I think that we stand together as a community to continue to move this field forward.
Going to the missingness of the data. So the normal star file for solid organs, for example, on kidney, you'd have each kidney transplant is one line, so it's a row. And UNOS merges this with the donor data from the OPO. So with that, since you register your patient and you provide the HLA typing for your recipient and unacceptable antigens, and the donor HLA is entered by the OPO, those patients do have HLA matching in that star file. So in VCA, does the star file link to the donor file as well?
The data that I received, the star file, there was like baseline data and like post-operative data. and it was not linked to donor-specific data, but there was one particular variable. Each of the variable, they all had different names and classes, and the HLA mismatch, that in itself is a variable that's reported in the OPTN. So when I report that in my analysis, I did not have the original raw data to look at and say, oh, this patient had HLA-A of this allele, or this person had HLA-DR of this allele. What I am reporting is the, quote, HLA mismatch. That alone, that number of loci, is a variable of report in my star files.
I'm getting some responses. You're okay. So there's a question here, which is the risk of VCA graft failure less than other solid organ grafts?
I think it would depend. It would certainly depend on the type of organ. I think, here at Duke, we do abdominal wall transplant as well as hand transplant. I think that each organ has their own unique challenges and their own unique capabilities. I'm not sure that I can just make a blanket statement on all as a group. I think that when we're proposing to do a VCA transplant, it is very important to very thoughtfully consider the risks and benefits to a particular patient, and to make sure that the benefits would outweigh the risks, as we would with any surgical procedure.
I would agree with you completely, because right now you don't really have enough numbers to show what the true half-life of these grafts are, and it might be very particular to each patient, to the inability to standardize. Which leads to a question: for the upper extremities, was there a level of amputation or transplant that's recorded in this data set?
That is reported to some degree, not universally for each of the transplants. There's also variables reported on the indication. How did the person lose their limb? Same question. Same goes for uterus transplantation. Occasionally, the indication or the reason for transplant of that organ is provided, but not always. That's one of those variables that we elected to not perform rigorous analysis on, just simply because it was not reported with a high degree of fidelity.
So the reason why a person had essentially a uterine factor infertility, whether it was...
Correct. That's one of the most commonly, that's the principally reported indication for uterine transplant.
Okay, and then there's a question here. Could you all speak a little more about what you are hoping to see in future research regarding the uterine transplant findings you discussed? Thank you.
Certainly. I'm not well versed in uterus transplantation. I'll be first to admit that. It's not a procedure we do here at Duke either. But I find it to be a fascinating field of immunological research. Firstly, because it's one of the only ones that we can do with a living donor, which I think lends a great opportunity for an immunologist looking at translational outcomes to assess the relative role, who is donating the organs, who is receiving them. Is it, a menopausal mother donating their child, donating their uterus to a child who may have Mullerian agenesis? What is the minimum number of immune suppressing drugs that are necessary? A uterine transplant really doesn't need to be in for more than 9 to 12 months. I would welcome other people's comments on that assertion, of course, but it's not necessarily a transplant that needs to be lifelong. So there might be important questions about minimum immunosuppression medications that would be necessary to sustain the fetus, but would be able to be weaned after delivery and presumed hysterectomy.
And I think you pointed it out very nicely in the presentation that one of the elements that I think both providers and patients and their families would want to know is defining a uterus transplant success is not simply having the uterus in there for a year, it's having a live birth.
Correct.
And then a healthy child. So essentially the number of live birth, how many fertilizations that had to be done, implantation, and after this, how did the children do long term? Did they grow up into normal adults, or were there any problems or defects?
Right. I mean, those are, we're certainly seeing children born around the world from VCA uteruses. And I think it's a fascinating field of inquiry from an immunological, from a surgical, from a public health perspective. I think these are important questions to discuss as a group. And I think that, the next step forward for that discussion will be making sure that we all work as hard as we can to report data to our governing body, which is now the OPTN.
Does the OPTN have a charge to follow the children after they're born, do you think, or that's outside their purview?
I'm not sure. I'm not sure on that, actually.
So I think Sweden, which started this with their first series, now actually the state is following all the children born to uterus transplantation. They're enrolled in the registry.
Well, it raises an important, I think, parallel when we think about reporting of OPTN, reporting of VCA data, and collection of OPTN data. For example, I would imagine that each of the centers that performs VCA has a lot of this data already at their center. Mm-hmm. I'm sure that each individual medical center that performs these surgeries stays in close contact with any one of their patients, whether it's through Zoom or telemedicine nowadays, or through regular biopsies or medical appointments. I think that the same would be said for the children born of a VCA uterus. I'm sure that they are not lost to follow-up globally, but whether or not they are assiduously entered into a database, that might be a different question.
Perfect. And then questions that could also be pertained here. So a definition of a graft loss. In solid organs, we're sort of familiar with it. Mm-hmm. What would be your definition of a graft loss in these various VCAs?
Right. That gets to an interesting point we had in the analysis of this manuscript. There is, as I described, variables that describe the number of acute rejection episodes. So for one person, that was documented to have 7. The number 7 was written as a variable for them. When we look at whether the organ was, quote, engrafted or in place for a certain amount of time, it's challenging to describe a VCA graft as, quote, engrafted, because we don't always know what's happening under the skin, so to speak. But one of the more highly reported variables is date of graft loss. And there's not always a very rigorous comment section added to the date of graft loss. But from an analytic perspective, we have to assume that graft loss was a catastrophic event for that patient. They must have come to the hospital, to their clinical center, days prior to that. Something must have occurred clinically. It's not always described. Sometimes patients are described as having a thrombosis or bleeding. Those variables are reported on occasion. But the date of graft loss, that is a sentinel event that's documented in there.
So in the current definition right now, is it like amputation or retransplant?
It's not defined. Death is not a variable in the OPTN database, actually. That's a question that we've heard before on this outcomes database. It's simply not in the OPTN variables that we received. But when we look at graft loss, that certainly is one. Of note, because graft loss is obviously such a huge and important clinical event for that patient, the patients who are not documented as having had a graft loss, for example, let's say one of our patients was documented as receiving their transplant in 2017, and I downloaded the database in 2019. If their graft was still in place, then they would have no date of graft loss. So in my Kaplan-Meier survival curve, they're notated as a graft still in situ, without having reported a graft loss. We presume that their graft is still in place and in situ because these VCA transplant centers do pay close attention to their patients. We presume that any graft loss would be such a catastrophic event that it would come to their attention and would be reported to the OPTN.
which takes me to some definitions, for example. So I really think there should be a defined definition of what that is. Amputation, patient death should be included as in solid organs. Retransplantation would be a failure. And even that doesn't touch the grayer sort of situation where someone has the graft but doesn't have good function from the graft, since these are intended for function, correct?
Correct. I think that, you know, having good functional scores for the hand and the face group, I mean, those researchers are to be commended for their assiduous attention to detail in terms of making sure they have good functional outcomes reported, because that would certainly allow the research community to look at VCA transplant and identify if it is a value-added initiative. You know, when we look at something like the Carroll test or the DASH score, we can use the value added of a VCA and compare whether or not that is a clinical benefit to patients. You know, when we look at outcomes-based data of prostheses versus replantation, major replantations, the data does show that replantation and these types of soft tissue transplantation procedures can often result in improved functionality as compared to a revision amputation.
Great. Which leads me to another, because you brought up the cold ischemia time and the warm ischemia time and the differences in there, and that you have a null variable, and some people have entered 0. So
yes.
Do you think that this is related to that it's truly that variable, or do you think that it's the provider's misunderstanding of what's being asked of them, or what defines cold ischemia versus warm ischemia? Has it been defined in VCA?
You know, thank you for that question. That gets into some of the nitty-gritty of my analysis, and it's a fascinating number, a mathematical question there in the analysis, because, you know, having been in the operating room during solid organ transplantations, we know that these are metrics that are very carefully recorded. You know, the circulator nurse or the scrub nurse, everyone in the room knows the time of cold ischemia and warm ischemia. It's written down very carefully and it's documented in our solid organs. And go ahead, I'm sorry.
Yes. No, so that's the question. So it's not whether they wrote it down or not. Do you think that the circulating nurse, for example, in different places may have defined cold ischemia and warm ischemia differently? Because
I would suspect that I would suspect that it is recorded, written down in the operating room, but I wonder if it's lost somewhere between the operating room and the data entry on the back end. Because I think that if someone were to report, I think 0 as an ischemia time must be an error. Maybe that number was not available or it was lost. But you know, the data entry person, they can enter a null value, they can enter a space bar or just leave it blank. But it must be an error for someone to have written in 0, because that drastically changes the mean ischemia time for these organ transplants. And I think that's one of the areas of important improvement, is looking at data fidelity and maybe asking the respondent, you know, entering the data, are you sure? Did you really mean to enter 0 for ischemia time?
Then that's the next point about this one as well, is for decannulation, for example, for the functional outcomes in face transplantation, where it says 50% had their tracheostomy decannulated. Is it the wording in the question that it's 50% of face transplant recipients had a tracheostomy that was reversed following the transplant, or that 50% of those with a tracheostomy were able to remove that tracheostomy?
So that is a difficult question to answer with the way the data is described. I will say that there's a variable called decannulation of tracheostomy, and the variable is either reported as positive or negative or missing. So, you know, either the patient has a tracheostomy that was decannulated, or they have a tracheostomy that was not decannulated, or the data is missing. For that question.
That's the question. So it goes back to the definition. So when we come to analyze this, it depends on how the question is and how it's recorded in the data set. So if you have 100 patients and all of them with tracheostomies and half of them would have it reversed, and that's 50% of those. But if you have someone who doesn't have a tracheostomy and then you're asking them were they decannulated following a face transplant, the answer would be no, but it's because they didn't have a tracheostomy before.
They didn't have one to begin with. Yeah, exactly. it is a tricky thing about the way these questions are addressed. You know, I've not had the privilege of seeing what the end user would see in entering this data. I just analyzed the OPTNs, like the SAS files that I was given. But I wonder, you know, what that looks like for the end user entering the data.
Do we have any more questions from the audience as we approach the top of the hour here?
Dr. Amer, it looks like that was the last question.
Perfect. So thank you so much, Dr. Lewis, for a very engaging discussion and lovely presentation and an excellent study. And thank you everyone for attending with us today.
Thank you all very much. I appreciate the opportunity.
AST would like to thank Drs. Lewis and Amer and to all of our attendees for today's excellent session. Please remember to complete the evaluation survey and visit myast.org/journal club or the AST YouTube channel to view our video archives and register for upcoming journal clubs. Thank you again.